Hello, Dr. J.C. Sharma again, and in continuation of rapid revision of cardiology, I will today deal with something difficult, I should say. Infective endocarditis. Difficult to treat. One has to have a very high degree of suspicion for the diagnosis, and with very devastating consequences, very high mortality. So this is what is infective endocarditis. Infection of the cardiac endothelium in the form of vegetation later on. Serious and life-threatening. Mortality around 20 to 30% in native valves and much more in prosthetic valves. 70% it is in certain high risk patients. In 75% of the cases, previously known cardiac anomaly. Multidisciplinary collaboration. Don't forget to consult and ask them to have a review of the patient. These other specialties like infectious disease specialist, a microbiologist, and of course a cardiothoracic surgeon. So the incidence is 1 per 1000 admissions. Quite much, I should say. What are the risk factors? Structural abnormalities. Important one. The another one is a prolonged surgery, reoperations, catheter-related bacteremia, intravenous drug abuse, the new entrant to infective endocarditis, relatively new immunosuppressant, fungal endocarditis. Sternal wound infection is also predisposing to the infective endocarditis and should not be forgotten. So what are the signs and symptoms? May be almost asymptomatic. We see the patients asymptomatic, some subtle symptoms of, say, some fever, malaise, pallor, and extreme weakness and those sort of things. 2. Cardiogenic shock. Myocardial failure, cardiogenic shock. Severe valvular disease culminating into very fast death may happen with acute infective endocarditis. So there are two phenomena with acute endocarditis. Number one is marked toxicity. There is a valvular destruction and there are metastatic infections. Important. May not happen with subacute one. It is only days to weeks. This is acute infective endocarditis. From weeks to months is a subacute one. It runs a little long course and it evolves around months. Mild to moderate toxicity only, not much, and rarely causes the metastatic infection, which is being caused by the acute infections, acute infective endocarditis. Rate of progression all depends upon the age of the patient, what is the underlying situation of the patient, and what is the valvular disease, valvular destruction which you find in the patient. The hallmark, I should say, fever and a murmur. Easy to remember. There is a fever, there is a murmur, there is predisposition to the infection like valvular diseases. These all may cause infective endocarditis. Fever may be absent, as I told you. In immunosuppressed people, it may be absent. In the elderly, may be absent. Murmur may be absent, in right-sided infections, like tricuspid endocarditis, or if there is an intracardiac device manifestation. This is not the infectious endocarditis devices and coarctations, PDAs, not endocarditis, because the heart is not there. These are extracardiac and should be named as infectious arterial infections. The endothelium of the artery is involved. So arthritis, infectious arthritis, not the endocarditis. Endocarditis you will call when it is the myocardial and endocardial things are involved. Non-specific symptoms, as I already told you, night sweats. These are something which we really find, and if you see the symptomatology, then you will be able to see that yes, these are present in many of the cases. Weight loss, because it is a chronic thing. Chills, fatigue, we have already talked. Aches and pains everywhere. So mural infections, if there is only a left endocardial or left ventricular endocardium, or suppose right sided endocardium is involvement, then there may not be murmur because there is no valvulitis. So these things are to be kept in mind when you deal with fever in a case of device implantation, valvular disease, in the cases of congenital heart disease. So these important things should not be ignored when it comes to infective endocarditis. So near murmur, a new murmur, we have talked. Congestive heart failure, why it happens? Aortic valve disease is most likely valvular disease. A valvular infective endocarditis which can lead to a heart failure. Mitral is the second. Tricuspid may also lead, but remember mitral and aortic and mitral, I should say. So what are the signs? Embolic signs or immune complex signs. These signs are present but less in number, mind you. That's why the Duke criteria has not involved these signs and have not given the importance to these signs much. They are there, but I should say very later and rarely found these days because of the regions, because of the changing scenario in infective endocarditis also. Earlier, the streptococcal viridans and bovis, those infections were very common. Now, staph is much more common. So, it is said that the peripheral signs are rare, less, because of the changing scenario of this infectious disease, infective endocarditis disease. So physical findings, as I told you, are embolic and immune complex, splinter hemorrhages, sublingual dark linear, these are the streaks which are really seen many a times, and even I have seen in one or two patients. Mucosal pathologies you can find, these hemorrhagic signs. These I will like to show you. When you see such things, look for the fundoscopy, for the broad spots. For academically also, it is nice to see. And clubbing, Genevieve lesions, embolic, macular, in the between, I mean in the center, they are macular. Osler's nodes, painful tender nodules on the fingers and toes are found. Splenomegaly is also found. Glomerulonephritis is another thing, not a physical finding, but we should not forget that takes place. These classical findings are neither sensitive nor specific. As I have told you, they are non-specific, and the neurological findings will also be found these days in the form of stroke, encephalopathy, mycotic aneurysms, meningitis, brain abscesses. Maybe because of the original disease they were suffering, or because of the infective endocarditis. So these things should be kept in mind every time, to the level that the rod spots are not much seen, and in that place you get the chorioretinitis, endophthalmitis, which are the non-specific things as far as the infective endocarditis is concerned. So the systemic embolization may cause acute coronary syndromes. Maybe a peritonitis because of the splenic, kidney and bowel embolizations. Stroke because of the cerebral embolization. Pulmonary embolization, obviously from the tricuspid valve endocarditis. Cold extremities, JNAV lesions are embolic, don't forget. Source of infection, very occasionally identified, may not be correlated with the dental procedures, may not be correlated with the infected vascular catheters also, a little later on. Infected skin lesions should be kept in mind, and the rheumatic heart disease, congenital mitral valve prolapse, these things are predisposing, and no need to say that in our country rheumatic heart disease is the commonest background lesion which will lead to infective endocarditis. In our country, mitral valve prolapse and bicuspid BAV is a second thing which happens. So the first, rheumatic. We move on to native valve endocarditis. Streptococcal infections and enterococcus, 1 and 2 number. Staph later on, HASEC after that. So HASEC and fastigious organisms are also there, and more or less these are the organisms which are responsible in cases when the culture may be negative. So you have to consult, extra plates are to be placed for these organisms to grow, and you have to remain in constant touch with your microbiologist. Don't forget to talk to them twice in a day. It's very important. So what are the HASECs? Haemophilus, Actinobacillus, Cardiobacteriums, Eikenella and Kingenras, fastigious organisms, and the bovis infections like colonic polyps and cancers, of course. And it warrants what? Why I am naming them? That you should look for endoscopy. If these organisms are grown, then you have to perform the endoscopy to rule out these very diseases which have caused this infective endocarditis. So the epidemic of opioid use, no need to say, becoming very common. Staph aureus is the infection in intravenous drug users. I will show you a very good list of what are the organisms which most of the time cause these. So in infective endocarditis of tricuspid origin, Staph aureus, tricuspid valve is number 1, and second valve, pulmonary, is very less. Particularly point out this fact that the mitral is the second one which can be caused by this. More than one valve can be caused by drug user infective endocarditis. So native valve, enterococcal may be there, genitourinary system may be there, obstetric procedures. These I am naming to keep in your mind that these things can happen. May not have an underlying disease also, even then, and they may not find a denuded endothelium, even then this may happen in acute endocarditis. Enterobacteriaceae, these are the organisms, you know them very well, including the Shigella, E. coli, Salmonella, and these organisms can be grown. To name them, because they may come after the culture and you may feel that these organisms are not very common to cause a valve endocarditis. Streptococcus pneumonia, what is the triad? Pneumonitis, meningitis, infective endocarditis. Congenital anomalies, bicuspid we have discussed. VSD very common, PDA very common, TOF is there. ASD, no evidence. ASD usually is not complicated by infective endocarditis. And Staphylococcus lugdunensis is the organism which may be there in the highly destructive. It destroys the valves, and death is very likely if you if this particular organism is coagulase negative staph. So very dangerous, as we know about the coagulase negative ones, and they are very resistant to the most of the antibiotics, and they have predilection for the native valves, very high mortality without the surgical replacements, and have to be kept in mind. Prosthetic PVB, important, within 2 months, less than a year, after 1 year. Keep it in mind that after 1 year, this is as good as native valve endocarditis regarding the organisms, regarding the treatment, and even the surgical replacements also. You can treat prosthetic valve endocarditis also if it happens after the 12 months of implantation of the prosthesis. So the first 6 months are 10 to 20% of the cases of all the prosthetic endocarditis. And something important I am pointing out, earlier there was a notion that possibly the mitral positions prosthesis, they cause more endocarditis. No, my mitral and aortic both are similar as far as the prosthetic valve endocarditis is concerned. Of course, nosocomial, we know this, and this is a intraoperative contamination. Coagulase negative, we have already talked. Fungi are there, very high mortality rate, but fungi with large vegetations of some 10 centimeters also may occur, and very high mortality. The recurrence after months and years after treatment, so disgusting to find these features of recurrence. Despite a very aggressive therapy, they may not respond very nicely, and on the top of it may recur on the another prosthetic valve also. So the mortality, disgusting situation, we have encountered around 3-4 cases like this, to the greatest disappointment of the whole of the team. So these are the things should not be forgotten, and we have come across many of these. Diphtheroids are the things which I wanted to point out, that yes, these can be pathogens rather than the sample mixing or commensals. So keep them in mind. Something very special about the prosthetic valve endocarditis. Why I am dealing with each and every one with the separate heading, because they deserve it. It is very difficult to treat, and once you know almost all the points regarding these, you will be at least able to handle these situations of, in fact, IE. There is a biofilm around them, and that insulates the antibiotics of the blood stream to go to the organism itself. So what is the treatment? Removal, surgical removal. So disruption of the biofilm by the mechanical removal is important. Mycobacteria can be grown, and they are grown somehow during the procedure, and these are the mycobacterium which live in the heating system of the perfusion system. So because it has been seen in many hospitals, and later on it was found out that this was the one. So it requires molecular fingerprinting, and possibly cannot be grown as far as the microbiology is concerned. Pacemaker, defibrillators, and these indwelling things may cause endocarditis. If they involve these structures, you can understand the horrifying things which may happen. So they involve the generators and the defibrillator pockets, electrodes. On the electrodes, one more thing which may happen is thrombus. May not be very infective. So if constantly, there is no fever, and constantly, if the organisms are not grown, take them as thrombus. The same thing that the first 2 months, the microbial seedling at the time of the operation, and the late infections are definitely the ones which cause the device erosion. You have to take them out, and eventually even we will try to take out the whole electrodes and everything. But good thing about them is that the hematogenous dissemination is very rare to be caused. So majority of the prosthetic, we have dealt with the native valve endocarditis. Now let us talk a little about the prosthetic valve. Staph aureus is the most important organism which is grown, and coagulase negative are the organisms which are there. So 90% of the early infective are coagulase negative. Late 50% Staph aureus, which may be positive also. In the same way, gram-negative bacilli in the form of enterococci and fungal, rare but happen. High mortality, we know, we have already talked about them. Culture negative endocarditis, in these cases as high as maybe 10%, on an average 5%, but in these cases 10% of the cases may not grow anything in spite of very meticulous techniques and multiple cultures being taken. Defined positive culture in 3 inoculations we will talk when we come to the Duke's criteria and other things which we will talk in detail again. So negative fastigious bacteria, fungus and all those things. Antibiotics prior to obtaining blood culture, which I wanted to point out, I should have kept this point on the top, but unfortunately we have forgotten. It is in the last, but it is not the last, but the first, my dear. Don't give antibiotics if it is not a dire emergency like acute infective endocarditis, and a few hours may matter most, and you have to give the antibiotics maybe even before taking the blood cultures, requisite cultures from 4 places. We will talk about them more, but antibiotics before blood drawing for cultures is very dangerous thing, and which may patient have to pay his lifelong. Even antibiotics within previous 2 weeks will not give good results and very difficult. One of the cause of culture negative endocarditis should be kept in mind. So the most common agents we have talked one by one, and just to have a list complete: Streptococcus, fastigious organisms in the form of fungi and insects. Bartonella is the one. Exposure to cats, Libman sac. Coxiella burnetii in the Q fevers and the Whipple infections, and are those, of course, an infectious disease specialist is required when these organisms are gone in your culture medias. So other endocarditis are Libman sac. We have talked about the fungus with very big vegetations of 10 centimeters and above. Intravenous drug users, fungal endocarditis, don't forget, we have many things grown when it comes to the intravenous drug users. Immunosuppression is an important point when it comes to fungal endocarditis. If the patient is taking something immunosuppressant for their other diseases, an important cause of infective endocarditis. The most common cause is Candida species. Others are Histoplasma and Aspergillus. We will talk about them. The fungal infective endocarditis, large vegetations, and I have already discussed about them. Perivalvular apparatus may be involved, and the large embolies are very common and we have already discussed about them. Surgery will definitely be required. So how this happens? The pathophysiology of the infective endocarditis. It doesn't start. That's why it has got a very insidious course, a vegetation formation. It is non-bacterial. NBTE forms for quite some time. But these are sterile and contains platelet and fibrin. If the organism goes, they go deep into it. So NBTE starts, and if there is a bacteremia due to these procedures or due to other reasons, then these NBTE will be infected. This is how the whole thing starts in most of the cases. So the vegetations form the nidus for these circulating bacteremia, and they start in the closer line of the valve leaflets, on the low pressure sides of the valves and the low pressure side of the ventricles also. So the endothelial injury by the regurgitant jets, I have already talked about them, and these are the vegetation they form in these particular places. So the foreign devices, no need to talk again and again. The platelet, fibrin and thrombi are formed where infective endocarditis takes place in the defibrillators and pacemakers. So this is how this dreaded disease starts. So bacteremia converts, I have told you people, the bacteremia converts non-bacterial thromboembocarditis into infective endocarditis. So this is a failure of the host. Maybe because of the many factors, because failure of the host will lead to infective endocarditis. Very difficult to treat also. The vegetations further impair the valvular coaptation, and this is the first thing which causes the regurgitation. Perforation, caudal rupture, these are all the sequelae of vegetation which are first formed on the leaflets, and the infection extend to the surrounding tissues within some period. Valve ring abscesses, cardiac conduction system, prolongation of the PR, complete heart block, adjacent myocardium is also involved. Mitral aortic intravalvular fibrosis is there and should be kept in mind. They form into fistulas and aneurysms. Abscess formation also takes place. So the fistulas may be formed within the heart chambers, within the heart, ventricles and other chambers. Very important thing. So what happens with the usual blood test? Very common thing, as in any of the infections, that there may be a leukocytosis, increased or decreased platelets, ESR is high, CRP is high, rheumatoid factor may be positive because of the immune complex phenomenon, hypergammaglobulinemia will be there, positive VDRL may be there, AIIMS not very common with us, and decreased complement and bun creatinine may be raised because of the renal dysfunctions. Glomerulonephritis, we have already talked that this may happen because of the emboli. Blood cultures in the critically ill patients, therapy should not be delayed. We have talked, but should not be delayed for more than 1 or 2 hours. Fulminate infection may be rapidly fatal. By the time the patient reaches to us, he is in a very difficult situation. 3 set of cultures, 3 venipuncture sites, different places with all aseptic precautions. So the commensals may not come in. Fungal always be included in immunocompromised patients. always be included, although you know that it takes a lot of time. So the first and the last drawn at the distance of at the interval of around 1 or 2 hours is important. Intravascular infection leads to constant bacteremia, meaning thereby that don't wait for the fever to come, and you can take the blood cultures anytime because there is always a bacteremia. It is unnecessarily to wait the arrival of fever, we have talked already, and the lab should be alerted. It's such an important point that talk to the microbiologist that we have got such and such patient and we are sending the cultures for this to enhance the culture mediums and for the prolonged incubation periods also. Essex group, may require even 3 weeks or so. Serology important, but may be revealing. These important things take time, but are important because you can start with the final treatment. Fastidious organism, no need to say that have to be taken care of. Tissue culture medium may have to be changed appropriately in consultation with the microbiologist. So these cultures are positive and you can see these things are very important. Lugdunensis I have already talked, but they are certainly encountered and should be looked into. Histological evaluation after the surgery and all the valve has been taken out is important still. Why? Because after the valve replacement also you will have to resort to antibiotics. Very important. At least after taken out the sample, after the surgery, must be detected definitely that what the organisms will respond to. Surgeons are very important. We will talk because we have completely another session, another some 10-15 minutes for our surgical colleagues also, because we will need their help in many of the situations, many of the settings. So the various stents and immunohistology are to be taken and should be seen very carefully. ECG, what happens? Baseline ECG always keep, so that if slightest of the heart block which may be reflective of abscess formation and paravalvular lesions in the conduction system should cause a alert to the treating physician, may lead to complete heart blocks also and myocardial infarction also because of the embolizations of the vegetations. CNS we have already talked, may cause myocardic aneurysms as well as the emboli. CHF, chest X-ray, not much in these situations but may show heart failure and effusions. Right-sided IV, there may be pulmonary infarcts and may be seen when in the chest X-rays also, should be kept in mind. Echocardiography, transthoracic as well as transesophageal. There are 2-3 situations when transthoracic echocardiography you may call it negative and you don't see anything. In prostatic valve endocarditis, if the vegetations are very small and less than 2 millimeters, but transthoracic echo even is very revealing, to show you the complications of endocarditis, valve perforations, dehiscences, abscess formations and heart failures and the other regions of coronary involvements and all this in echocardiography. but T is also there. So just read them out for our benefit, that the intracardiac locations may be seen in transesophageal, very difficult to see, mind you. Valvular, easy to see. In the same way, underlying cardiac abnormalities we see, and the possibilities of all the complications. If first echo, it is a dictum that if first echo is non-revealing and negative in the usual sense, do it after 7 or 8 days. There are many surprises for you. In the same way, assessing the posterior structures, very important. You may not see in the transthoracic. Right-sided structures, better see the transesophageal. So important things to see. Transesophageal may be a primary procedure also to rule out in very sick patients. And prosthetic valves, I have already talked. Limited echo windows in COPD patients, in thick set patients, very difficult to see transthoracic. So only thing which will help you will be a transesophageal one. So these are known to cause the endocarditis. If a organism is grown, then you have to look very meticulously for this. I have already talked and told you about the small vegetations which may not be visible as far as the transthoracic echo is concerned. Myocardial abscesses are also, because there the surgical interventions will be required, so it is important to have a look from the transesophageal, from the near of the heart also. Complementary imaging to CT, not very helpful in these direly ill patients. You don't have to do much. And the fungal endocarditis, Q fevers, we have already talked them. There are many differentials like myxomas and papillary fibroelastomas which may be there and have to be, if there is a culture negative, they have to be differentiated from the vegetations. So non-bacterial endocarditis, these pictures may show you, and the fungal ones are very important as far as the culture negative endocarditis is concerned. All the meta-analysis, previously there were less information available, but after the meta-analysis we have found that the embolizations are more common in big vegetations, 3 times higher in 10 millimeters. Small vegetations may not cause that much. Prolapsing vegetations, extravalvular structure, increased risk of heart failure. Important to look into, and replacement is needed. Increase on the size of the vegetation despite the therapy will require surgery, as you know. So these are the important things to see into the patient with the help of transesophageal, transthoracic and repeated transthoracic examinations. I think we have covered these aspects earlier also, but you see, suspected pacemaker and defibrillator endocarditis should be ruled out by the transesophageal ones. The thrombus formation I have already talked. Cardiac catheterization doesn't play a role in infective endocarditis except in the situations that if you are going to operate the patients, look for the coronary arteries as well. So if there is something to be operated along with the main operation, index operation, you can do it. CNS imaging, we have talked about the mycotic aneurysms in FACS. Body imaging for metastatic infections may not be needed much and should not be wasted time for. So what are the common therapies? The therapy of infective endocarditis, indwelling catheter. Just keep that. Our rule in our institution is to put a long intravenous line, central line which starts from the antecubital veins and reaches up to the superior vena cava either or right atrium. These lines are available in the market and can be put even without the help of fluoro, and very important because you will see later on also all the therapies, they last not less than 4 weeks, maybe more than 6 weeks also, but are not less than 4 weeks. To keep the peripheral IV cannulas this long or even longer than 2 to 3 days are very difficult. You know this very well as practicing physicians. These are the problems you will come across and should be dealt when you start taking the patient of infective endocarditis for therapy. So penicillin G 12 to 18 millions, important in 24 hours. Maybe the infusion or in divided dosage should be continued for 4 weeks. Important thing, Ceftria for 4 weeks, 2 gram. Maybe given IM also, but we give IV. Penicillin G with Ceftria plus gentamicin. If allergic to these, then Vanco. This is the main therapy, more or less, should be tried in and are to be taken into consideration when we talk about the streptococcal infections in form of bovis as well as viridans. So the standard therapy for enterococcal, penicillin G, and nutritionally variant viridans, endocarditis, prosthetic valve endocarditis due to strep viridans and streptococcus bovis. These are the 2 organisms you know of streptococcal. So the penicillin G 24, a little more, and duration. Notice the duration, very important. Notice the duration, 6 weeks, my dear. Very difficult to treat this endocarditis. Ceftria with or without gentamicin. If penicillin allergy, vancomycin. So these are the standard, and I have given you in the different charts. So when you see the organism, you start the therapy according to this. Antifungal, what are the therapies? You have heard a lot about amphotericin B when it came to the black fungus of COVID-19 sequelae and the dreaded things you have heard just 3-4 months before. So amphotericin B infusions over 2 to 4 hours are important in these dosages which I have told you. When you are dealing with the prosthetic, asparagus is also involved, and the amphotericin B is the treatment of choice. You can see the renal dysfunction is important. You might have heard also that the renal dysfunction is there, and liposomal preparations possibly not available in our country, but they cause, and they are less toxic. The primary toxicity of fluocytosine is a bone marrow depression. Should be kept in mind. Very important, because you may need more than and other than amphotericin B. Staph, native valve, nepenicillin, oxacillin, if allergic to cefazolin. Oxacillin resistant strain and penicillin resistance, vancomycin, methicillin and daptomycin. These antibiotics are to be kept in mind when you are dealing with the staphylococcal native valve. Therapy again, mind you, 6 weeks. So infective endocarditis due to staph in the presence of prosthetic material, gentamicin and rifamycin, in addition to the oxacillin and nepenicillin. Keep them in mind. Don't forget the duration of the therapy here. I wanted to point out 6 weeks, but for aminoglycosides like gentamicin, 2 weeks. Review the situation. Because of the ototoxicity, because of the nephrotoxicity. Important to remember, gentamicin, don't continue with it more than 2 weeks. You have to consult an infectious disease specialist. We have to consult all the parameters and you have to re-look into the patient to continue with the gentamicin. So therapy for the HASEC, Ceftria, ampicillin and ciprofloxacin. 4 weeks duration is the minimum, which is all is required for these 5-6 organisms. Therapy for prosthetic valve, enterococcal species, again very difficult thing, ampicillin and genta. Ampicillin resistant, gentamicin resistant, Ceftria, penicillin resistant plus genta. 4 to 6 weeks and 6 weeks duration. Keep these charts in your mind, and dosages as usual are very high and should be given in divided dosages and minimal requirement should be completed. So what are the complications? We divide them into cardiac and extracardiac. Cardiac are more lethal and lead to deaths, which are common, which are there with the infective endocarditis, heart failure, bleeding, abscess formation, pericardial, aortic annular, myocardial also, conduction abnormalities. Due to the invasive disease which you come across many a times, coronary embolism is there along with the cerebral embolism, valvular regurgitation, flail, perforation, long-term stenosis, prosthetic dehiscence is there, septal perforation have been recorded. So extracardiac, what are they? Stroke, we have talked, renal infarct, splenic, limb ischemia, rare, but if it is a large fungal emboli, it can happen. Abscesses and immune complex deposition leading to glomerulonephritis. I already gave you the hint about it. Factors and complications that predispose to a poor outcome. What are the factors which you can predict will lead to maybe a failure of the therapy? CHF. Most important prognostic factor. Non-streptococcal disease like staph, enterococci and others. Aortic valve involvement more lethal than what it is on the mitral valve involvement. Infection of the prosthetic valve may have to be changed once or even twice. Older age, abscess formations, HIV. With these counts, those who are dealing with the HIV should take care of this. Delayed diagnosis, of course, will lead to all the complications before you embark on the therapy. Recurrent infective endocarditis, dreaded, ultimately takes the life. Very disgusting for the treating doctors and with the horrible outcomes. The cardiac conditions associated with the highest risk of adverse outcome, prosthetic, again keep these charts in mind every time you deal with infective endocarditis. Mind you, in the beginning I gave you the introduction that this is not a simple disease to treat. Prosthetic valves, previous endocarditis, always chances of failures. Unrepaired cyanotic heart diseases, very bad situations and settings where infective endocarditis will happen. Repaired CSD and with the residual defect are also the nidus for infective endocarditis. During the 6 months of congenital heart defects, using the prosthetic material, which many of the times the surgeons are increasingly using in TOF repairs and the pulmonary artery repairs, may be infected, my dear. Cardiac transplant recipient may develop a valvulopathy. Disgusting, but may happen. So, recommendation for prophylaxis of dental surgery. What are the situations where it should be recommended that a infective endocarditis prophylaxis should be given? In the list, these are less. This is my general comment, because we in our country require more aggressively as far as the prophylaxis is concerned. Only recommended in the patients with the highest risk, because they say, one school of thought says that even after the normal chewing also there is a bacteremia, and it is no different in the usual dental procedures. The oropharyngeal procedures, the dental procedures involving the gingival tissue, periapical tissue, perforation of the oral mucosa, important. Tonsillectomy, important. Respiratory procedures, you know them very well. HASEX, they can come. So give prophylaxis. Procedures with the infected skins and musculocutaneous tissue, we forget usually, but important to give a prophylactic treatment. So what are the regimes, standard regimes? Amoxicillin, IV, orally, or ceftriaxone. Important things. If there is a penicillin allergy, Clinda, cephalexin, azithromycin, or a clarithromycin. Clarithrol also we have given in quite a few patients. So 600 milligram before 1 hour of the procedures, 2 grams cephalexin before the 1 hour, and 500 milligram before if it is clarithromycin. So these antibiotic prophylaxis are important, should not be ignored. So this is one list, ACC/AHA recommendation for the interventions. So what are they? Early surgery, I mean the same day. When I talk to class 1A indication, it is very important that the surgery be undertaken almost on the same day, and if delayed, on the second day. So early surgery is indicated who present with the valve dysfunction and results in the symptoms of heart failure. Important. Early surgery is indicated in left-sided endocarditis, specifically if staph, fungal or highly resistant organism. Early surgery again is indicated if there is a heart block, if there is a aortic abscess, para-aortic abscess, and the destructive lesions are there, which you see in the lugdunensis sort of things. Early surgery is indicated with the evidence of persistent bacteremia even after 5 to 7 days of intense antibiotic therapy. Important. Mind you, I have kept the chart intact. I didn't want to disturb this chart because should be performed as class 1. Complete removal of the pacemaker and defibrillator systems are, of course, advised and are done. Prosthetic valve and relapsing infections do on the same day. 2A recommendations are highly suggested and should be done. Recurrent emboli, persistent vegetations even after days of therapy, 2A recommendation. Complete removal of the pacemaker and defibrillators are required. Without the foreign body removal, infective endocarditis is not to be treated, my dear. That is sure. 2B indications are somewhat plus and minus, but look into them. Very important one. Vegetations which are mobile, likely to embolize more than 10 millimeter. As we talked earlier, that there are more chances of embolism in such patients. Operation without delay may be considered in cases who have suffered a stroke, because it may recur and may be life threatening. This chart has come a little later on, but very interesting to see in the last, that what are the organisms and what are the things which happen in native valve, intravenous drug user, early prosthetic valve endocarditis, late prosthetic valve endocarditis. So it is in such a way arranged. Just see, native valve endocarditis most of the time is what? Streptococci. Maybe viridans or bovis. Enterococci in 10% only. Strep only 25%. Coagulase negative only 5%. Fungi less than 5%. Culture negative less than 5% in almost everything. Other than early prosthetic valve endocarditis, where these can be detected quite early. So intravenous drug user, what is the most common? Staph. Look, very clearly written. See this very carefully and everything will be very clear in your mind, that what are the organisms most of the time involved. So coagulase positive most of the time. Coagulase negative less in intravenous drug users, luckily I should say. Early prosthetic valve endocarditis after the implantation. What is the commonest? Staph again. Dreaded disease, staph. But this happens. Most commonly this is the organism. Positive is 20, but negative is the problem. And again these are the negative staph which are involved as far as the early infection of the prosthetic valve is concerned. Late infections, as I told you, as good as the native valve endocarditis in the form of Streptococcus, both of the strains, viridans and bovis. Bovis has been renamed as a gallolitus. So you just check in the textbook and you may find a little different name, including the Harrison. So I have again revised this and taken it from our textbook of Harrison, and it's very interesting to see that when and how early the surgical intervention should take place. Aortic regurgitation causing pre-closure of the valve. Diastolic mitral regurgitation, if it is there, do it. It is very important. It will lead to death. Sinus of Valsalva abscess, if ruptured into, as commonly is done in either right atrium, most commonly right ventricle, do the surgery. Valve obstruction by a vegetation, very obvious to you, should be done like a myxoma, right there. Unstable prosthesis, remove them. May take another day, but I will advise on the same day. A dehiscent valve may lead to death within hours also, don't forget. There is a septal perforation, do it then and there. Perivalvular extension of the infection, do it in days, 1 or 2 days, very important. Lack of effective antibiotics, do it. We talked earlier also that the surgery is indicated and early surgery indicated. So these are the, like fungal endocarditis in the last of the list, you can see they are antibiotic resistant things, and candidas and those things have to be dealt with removal, surgical removal. There is no other therapy which can work, my